Good morning, everyone. I'm presenting today as Dr. Godinho. He is a specialist physician and EC PhD at the University of Victoria in 2009, followed by a Master's of Medicine in Internal Medicine from the University of the Witwatersrand in 2017. In the same year, she became a Fellow of the College of Physicians through the College of Medicine of South Africa. Dr. Godinho practices at Midstream Medic Clinic, and we are very happy to have her here. She believes in individualized and proactive preventative care. Dr. Godinho.
Thank you very much. So today's topic is always, what to choose to present. This is a fairly straightforward topic, considering all the kind of highly specialized talks we've had as well. But hopefully it's sort of a universal topic that applies to any medical professional. So I'm presenting an approach to obesity. Okay, so what's very important to understand is that it is a multifactorial disease. It was defined by the WHO as an abnormal excessive fat accumulation that presents a risk to health. As I said, it's multifactorial. In the USA, 69% of adults are overweight or obese, and the global prevalence is increasing. And in 2015, which is now quite long ago, it was estimated that 603 million adults were obese and 107 million of children. And by the year of 2030, it is estimated that 1 in 2 adults will actually be obese. Coming back to the multifactorial, it is affected by genetic, neurologic, metabolic, enteric, and behavioral processes. It is a key modifiable risk factor in many comorbid diseases like diabetes, cancer, obstructive sleep apnea, etc. But it essentially can affect any organ system. And due to the prevalence and consequences, it is responsible for a huge financial burden on the healthcare system. Goes without saying. So the pathogenesis, you just have to understand how energy regulation works. It's quite simple. It's basically this delicate balance between energy intake and energy expenditure. So if you have a positive energy balance, you're going to have weight gain. Genetic and environmental factors play a role in creating this positive energy balance. And this might be surprising to some people, but hereditability of obesity is thought to be between 40 and 70%, which is quite high. And there are multiple apparent obesogenic genes, gene-environment interactions, which contribute to how hereditable it is. In other words, whether you develop obesity or not will be exacerbated or reduced by environmental factors such as diet, exercise, and smoking. So some of the environmental factors that affect obesity is just, the presence or the availability of palatable food, altered consumption habits and patterns. So, maybe you get used to portion sizes that are too large. That's an example of that. And then decreased physical activity in occupational and leisure settings. So people sit behind the desk when they work, and they lie next to the pool when they're on holiday, and they don't get any physical activity. And then there's also the use of medications that may actually exacerbate weight gain as a side effect. Altered sleeping patterns. If you're not sleeping well, there's a severe lack of sleep. There's this constant increase in your cortisol levels. This is contributing to the way you eat and the weight you gain. Social factors are also fairly important. Financial instability, lack of food security, lack of healthcare access, and lack of education are all contributory factors. So the energy intake or caloric intake is regulated by enteric sensory pathways. This then results in vagal afferent signaling and endocrine cascades. It activates the brain areas where, that control appetite and the way feeding behavior. Energy expenditure, on the other hand, is 70% of this, which is quite high, is your basal metabolic rate, and the rest is a thermic effect of food and physical activity. So you burn it off. So this is like a very nice diagram that explains, the important areas of the body that are controlling hunger, feeding, and how much you take in. So the stomach, for example, on the right-hand side of the diagram, controls gastric emptying. And when gastric emptying is increased, that is associated with obesity because you have decreased satiety and increased hunger. And then as a meal then travels through the stomach to the duodenum, and enteroendocrine receptors will release hormones that are either appetite-inducing, like ghrelin, and anorexogenic, which is appetite-suppressing, which is glucagon, like peptide 1, peptide YY, and cholecystokinin. And then on the left-hand side, adipose tissue, fat tissue itself, will also release hormones, leptin and adiponectin. Leptin works in the hypothalamus. It will stimulate satiety. It increases your metabolic rate and therefore will increase the rate at which you burn energy. And it opposes this positive energy balance. It's also important in reproductive function. Adiponectin increases insulin sensitivity and promotes the breakdown of fatty acids. And paradoxically, while even though it's produced by adipose tissues, its levels will actually decrease obesity. So it's like almost like a negative feedback system as well. So I'm highlighting this because it becomes important in the treatment and management. What does GLP-1 do? It has many effects, and therefore a GLP-1 agonist treatment will, mimic this effect. It enhances a glucose-dependent insulin secretion, suppresses glucagon, it delays that gastric emptying that I spoke of. It also directly promotes satiety and reduces your appetite, promotes beta cell health, and it has a whole lot of cardiovascular benefits listed on the left. It improves endothelial function, reduces inflammation, lowers blood pressure, and this is how it also reduces major adverse cardiovascular events in patients that are at risk. So just to go through some of the complications, as I said, it can affect basically any organ in the body. There's a very scary picture of a man, but these are the kind of scary complications as well. The cardiovascular disease, it will contribute to hypertension, heart failure, coronary artery disease, atrial fibrillation, myocardial steatosis, as well as stroke and venous thromboembolism, pulmonary embolism, and deep vein thrombosis. And the other thing is cancer. You are more likely to develop cancer and you're more likely to die of cancer if you are obese. Some of the contributing factors are the sex hormone metabolism, insulin-like growth factor levels, and adipokine pathways. So which cancers does it actually have an association with? It's endometrial, gastric cardia, colon cancer, rectum, biliary tract, kidney, breast, pancreas, esophageal adenocarcinoma, multiple myeloma, hepatocellular carcinoma, meningioma, and ovarian cancer. So the list is long. The more kind of well-known complication is musculoskeletal. Obviously, it causes osteoarthritis because of the increased weight on the big, usually it's the large joints, and there's increased wear and tear of these joints, and therefore you have degeneration of the cartilage prematurely. And gout, increased uric acid, is associated with metabolic syndrome, which is obviously what you find in many of these patients. The gastrointestinal complications, it's associated with metabolic dysfunction, associated steatotic liver disease, which is also known as the non-alcoholic fatty liver disease. There's an association with gallstones. Because of increased intra-abdominal pressure, you get gastroesophageal reflux, and then hernias, basically all types of abdominal wall hernias and hiatus hernia. Yeah, the gynecological complications are quite a lot. It's associated with infertility, you get abnormal uterine bleeding, endometrial hyperplasia and carcinoma, and ovulatory cycles, as you see in polycystic ovarian syndrome, uterine fibroids, endometriosis, sexual dysfunction, and then pregnant individuals that are obese will be at a much higher risk of perinatal complications. So the genitourinary complications, obviously the obesity is associated with many conditions that compromise kidney function, like diabetes and hypertension. But obesity on its own is also independently associated with the development of chronic kidney disease. You also can have an increased risk of kidney stones. And in females, obesity is associated with urinary incontinence because of the prolapse, bladder prolapse, and pelvic floor that may be weakened. Obesity then also poses many challenges when taking care of dialysis patients, for the simple reason that there might be difficult vascular access. Your dialysis catheters will have an increased rate of malfunction. You get an increased risk of peritonitis in patients with peritoneal dialysis. And the patients may require more frequent and longer dialysis to actually obtain adequate clearance. The respiratory complications, asthma, obstructive sleep apnea, and then obesity hyperventilation syndrome. With this, you get altered pulmonary function, which will cause an increased residual lung volume, which is associated with increased abdominal pressure on the diaphragm, decreased lung compliance, increased chest wall impedance, VQ mismatch. And then you also have reduced strength and endurance of the respiratory muscles and reduced respiratory drive. So these patients can have, type 2 respiratory failure with hypercapnia. If you're obese, you're also more likely to have respiratory complications from infections like seasonal influenza and COVID-19. And there's an increased risk of atelectasis in general in patients that lie in bed or in patients who are post-op. So some of the skin changes, I saw such a good example the other day, and then I want to kick myself for not taking a photo, but this picture is acanthosis nigricans. It's not a very overt example, but basically it's described as a kind of hyperpigmented velvety plaque. It's usually in the skin folds, and you get it because of hyperinsulinemia that you can see in obesity, type 2 diabetes, or PCOS. You can have striae, which is basically stretch marks, and fungal infections in the moist skin folds, and hirsutism, particularly in PCOS. And then there's a significant psychological impact with social stigma, depression, lack of confidence, and I've written that twice, and loneliness. So how does one assess a patient with obesity? You might want to delve into if it's something that they've, a predominant thing that they're battling with. When was the age of onset of weight gain? It is significant if it's been since childhood. Are there any specific events or specific time period where the weight gain may have started? You want to delve into their dietary habits a bit, see if they've changed any of their dietary habits. Do they exercise? Have they had any attempts at previous weight loss? Have they attempted any kind of dietary modification? What was their success rate? And you want to know about their past and current medication history to see if there's anything that could be contributing. And is there a history of smoking cessation? Because that's also associated with the increase of weight. And do they have existing conditions already diagnosed, contributing to their cardiovascular risk that may lead to or have caused obesity? And then do they have any current complications like osteoarthritis, fatigue, symptoms that could be attributed to their weight currently? To mention some of the medications that cause weight gain, it's typically your antidepressants, antipsychotics, mood stabilizers, antiepileptic medications. So a lot of the medications that psychiatrists might use or neurologists. If they're on corticosteroids, it also promotes hormonal contraceptives, endometriosis treatment, antihistamines, and then very commonly antiretroviral drugs. So when you're doing your physical examination or assessment of this patient, BMI remains an important measurement or calculation. You want their weight and their height, and then you can calculate their BMI, which is basically weight in kilograms divided by their height in meters squared. For Caucasian, African, and Hispanics, you have those categories where underweight is less than 18.5, normal is 18.5 to 24.9, overweight is 25 up until 30, which is considered obese. And then you can divide the obese into class 1, class 2, and class 3, with 3 being 40 and up. For Asians, though, the cutoffs, if you use the above cutoffs, you're going to really underestimate their risk. So the cutoffs are lower. Overweight is from 23, a BMI of 23, and obese is from 25 and up. So BMI, when you talk about BMI, and I find this quite often when I talk to patients about BMI, they kind of roll their eyes and say, well, it's not, BMI is not all, because it's also to do with your muscle bulk, your, can be affected by your build. But the reality is it is still directly associated with an increased risk of heart disease, diabetes, hypertension, dyslipidemia, and hepatic steatosis. And the higher your BMI, the higher your risk will be. Waist circumference is also something you should do in patients with a BMI of 25 up until 35. I think above 35, it's not really going to give you any extra information because they're most likely above the cutoffs. For a male, it's 102 centimeters. For a female, it's 88 centimeters. And then again, for Asians, it's the cutoffs are significantly lower. So how you measure it is with a flexible tape, and you place it on a horizontal plane at the level of the iliac crest, looking from the front. So when you do your physical examination, you want to always include a blood glucose measurement. You know, on the odd occasion, you'll pick up overt diabetes that is undiagnosed. Skin changes, you can obviously, like I mentioned, you get these and you can pick them up, acanthosis nigricans. If you may have stria, but if you have purple stria, you might think of something with Cushing's. Skin infections, they may have plethora. If they have obesity, hyperventilation syndrome, for example, they may have a chronic hypoxemia resulting in polycythemia and plethora. Increased neck circumference is important. I haven't really included it in the presentation, but for those who don't know, there's a questionnaire called a stop bang questionnaire. It includes your neck circumference and various things. I think it also has BMI and hypertension, and it's basically a point scoring system. And according to that, you can estimate the risk of obstructive sleep apnea and whether you should evaluate the patient further. Thyroid, they may have a goiter, osteoarthritis, they will have crepitations in the last joints or Heberdin's nodules on their hands. Abdominal, like I said, you want to know whether they look at the stria, what do they look like, and you're going to take note of the central obesity or Apple Android figure, because that is, you know, correlating to visceral fat and then also correlating with your cardiovascular disease. If very advanced, you may find features of chronic liver disease and established cardiovascular disease. And then in a diabetic, you need to look for all of the complications and target organ damage that you might find. So the basic investigations that you should do on every obese patient and overweight patient is the fasting glucose and HbA1c, fasting lipogram, thyroid function, and liver function test, and an ECG. Then after that, you know, depending on what you're looking for, you're going to extend and do more investigation. Maybe you want to do an arterial blood gas to look for that type 2 respiratory failure with hypercapnia. You may want to do a lung function test, a heart sonar, polysomnogram, and then x-rays and imaging according to what you are looking for. And then cancer screening is important. You know, this is in every patient that you're following up chronically, but also to remember in the obese patient, and particularly younger patients that are obese, you might want to also look for it. And then if you think there's a secondary cause, you could do 24-hour free cortisol and all of those investigations. So your risk stratification is important. Low risk is when you are within that overweight category of BMI without any cardiovascular risk. Moderate risk is overweight with an additional cardiovascular risk, or BMI of 30 to 34.9, so class 1 obesity. And these patients, you need an intensive multi-component behavioral intervention, and you may consider pharmacological therapy. High risk is class 2, class 3, and you're going to be very aggressive with your management because in these patients, you really need to get the weight down in order to prevent cardiovascular complications. So the management, the comprehensive lifestyle intervention is needed. This is diet, exercise, and behavioral modification that then form the cornerstone. Just to indicate how important this really is, there was this diabetes prevention program, which was a multi-center clinical research study designed to determine whether lifestyle interventions or medication can prevent or delay type 2 diabetes in people that are at high risk. And the study was done in the United States in the 1990s. And it's very important because it showed that there was a 58% reduction in the risk of developing type 2 diabetes in patients who had the lifestyle intervention. And then a 31% reduction in the patients who had were given metformin 850 milligrams BD. So it does not help them to, or you're going to be less effective by just writing a prescription for metformin. You're going to achieve more by trying to implement lifestyle modification in high-risk individuals. So diets, I mean, I have not gone into this in detail because I think it's like a topic on its own, but there's a lot of diets and fads, trends considered in and around this topic. But basically, diets of 800 to 1,200 kilocalories a day seem to be effective. And it's not so much how detailed and perfect the diet is that's going to determine success. It's the long-term success is going to have more to do with the adherence. So it has to be something, a diet that a patient can stick to on in the long run. Regular follow-ups are critical. Then if less than 5% body weight is lost in a period of 6 months, you need to really reevaluate your strategy because you're not achieving sufficient weight loss to impact their health. Exercise actually is slightly less potent than dietary restriction in promoting weight loss, but it is a strong predictor of weight loss maintenance. So patients who start exercising will and incorporate it into their lifestyle will be able to maintain this. And generally speaking, if you're only implementing diet, no exercise, it's the effect is compounded by both. You need a combination of both, essentially, is what I'm trying to say. 30 minutes of exercise 5 to 7 times a week, and you need a combination of aerobic and resistant training. I mean, most of the information I read was quite vague on this, but I think it's probably best not to leave it open to interpretation too much to your patients. But yeah, they need to do cardio and they need to do weights. That's what it means. Behavioral therapy. So the goal of this is to make long-term changes in their eating habits and behavior. So they need to modify their food intake, their physical activity, and trying to control triggers that might lead to overeating. So it's kind of important that there is this sort of support system for this patient. Can they join a support group? Can they is there some sort of program, and who's going to follow them up? Because if they're doing it on their own, it tends to be slightly less successful. And then what everyone, including patients, want to know, what is the pharmacological treatments available? You're going to consider it in patients with where you've done lifestyle interventions, and you've trialed this and it's failed, and in patients who have a BMI of 30 or more, or even a bit lower, 27, and they're having comorbidities. So this is the kind of most effective treatments available. They are incretin-based therapies. The bottom two are GLP-1 agonists. The top one is a GLP-1 and a glucose-dependent insulinotropic receptor agonist. Why Tirzepatide or Mounjaro is at the top. It's got a star. It is the most effective. And then the two other, semaglutide and liraglutide, are also quite effective because of the multiple mechanisms in which they work. These agents are injectable. They subcut injections. The top two are weekly injections. The bottom one is a daily injection. The hearts next to the Ozempic and the Saxenda, or the semaglutide and liraglutide, are there because they have got proven cardiovascular benefit. We assume that this proven benefit will also translate to the top one, Mounjaro. It is available in South Africa. It's being launched, I think, at the moment. And but just to note, the dollar signs, because these drugs are very expensive. The top one, we're talking about plus minus 4,000 Rand per month, depending on where you get it. So the alternatives to these treatments, so if there's no cardiovascular disease or uncontrolled hypertension, which you can imagine excludes quite a lot of patients, because the reason why you're doing this is to lower their cardiovascular risk. So what are the chances of having no cardiovascular risk? But you do find these patients, younger patients especially, and the most effective drug there is phentermine and topiramate combination. We do not have this in South Africa. We have got Duramine, which is the phentermine, and Topamax, which is topiramate, is antiepileptic. So, and the dosage there that is recommended, it's quite, I don't think it's possible to give that exact dose in South Africa as two separate drugs, because Duramine is 15 milligrams, 30 milligrams. It's also a capsule. So I don't think, you can't break it. And the Topamax is a bit closer. It's 25 and 50 milligrams and up. It is contraindicated in coronary artery disease, hypertension, pregnancy, hypothyroidism, and patients on monoamine oxidase inhibitors because of the sympathomimetic effect. You do get tachycardia, and this is going to be, it's going to compound the effect if they already have, say, hypothyroidism. And some of the adverse effects, dry mouth, hypertension, as I said, tachycardia, and then you can have cognitive and psychiatric abnormalities, and then it is a contraindication in substance abuse for obvious reasons. You can't be on this and be using cocaine, for example, because you will have a heart attack. Duramine on its own, it can be used, and we do use it in South Africa, but it is a sympathomimetic. It does have a lot of side effects. It does have all those cardiovascular problems, so it's not in people with cardiovascular risk, and it's ideally not for long-term use. So the naltrexone bupropion combo drug is the next one. It's Contrave. We do have that in South Africa. It's second line because it's lower efficacy compared to the above. Bupropion is a dopamine reuptake inhibitor and used for depression and smoking cessation. And naltrexone is an opioid receptor antagonist using alcohol and opioid dependence. So I just remember when the drug rep saw me for this drug that they told me, think of those emotional eaters, and where food is like a reward to them. Those are the patients where you might have success, with this medication. So you have to choose your patients carefully. Some of the adverse effects are nausea, dizziness, constipation, headache, insomnia, dry mouth. And it's contraindicated in seizure disorders, which is important to know. It does lower your seizure threshold. And then chronic opioid abuse, because it's, opioid receptor antagonist, you're not going to use it for that. And severe hepatic or renal dysfunction, you can't use it. And I'm mentioning the last one, orlistat, Zenocal. It's also kind of second line or third line rather, because of reduced efficacy and because of poorly tolerated gastrointestinal side effects. So it sounds lovely, reduce HbA1c, reduce blood pressure, improves lipid profile. And then if you read their adverse effects, it really sounds like a nightmare: cramping, flatulence, stool incontinence with oily spotting, and flatus with discharge. So I'm not sure how many patients will want to give it a go, but it is an option. Again, not in pregnancy. You can't give any of this stuff in pregnancy. In malabsorption disorders, because the idea is it causes malabsorption. Patients with calcium oxalate stones and cholestasis. How should you follow them up? You should follow them up on a 3-monthly basis, actually. And if you don't see that in 12 weeks on the drugs that the weight is decreasing by 45% of their total body weight, then the drug therapy is not effective and should probably be discontinued. And you need to go back to the drawing board and consider whether your lifestyle intervention has been adequate. If the drug therapy is effective, it should actually be continued indefinitely. I get this question often, how long can I be on it? Because cessation of therapy is associated with weight gain. This does not apply to the sympathomimetic, because that's not for long term. And you can obviously consider bariatric surgery if they meet the surgical criteria and they are of a specific weight. So the take-home messages that I wanted to bring across is just that obesity is a growing global health problem. It has multiple comorbidities and complications. As I said, it's multifactorial. It's not just environmental, as somebody might assume. And a thorough evaluation and then an assessment of the patient's risk is essential. And then lifestyle modification in the form of diet, exercise, and behavioral changes is your cornerstone of management. And the most effective drug therapies with cardiovascular benefits are incretin-based therapies. However, these may be costly.
Thank you so much, Dr. Godinho, for insightful presentation. And obviously, I think I would always say that this is like an obesity made easy and it's easy to understand. And I think for me, that's really quite one of the things that we're going back to the basics about how to approach obesity. And Dr. Godinho, I have 2 questions for you. One is that in 2021, Americans Association of Endocrinologists, what they did, they redefined obesity. Instead of calling obesity, they kind of changed the term to adiposity-based chronic disease, because obesity itself is really, it's no longer a normal problem, but it's still a chronic problem because it comes with, as you alluded in the presentations, comes with a lot of chronic conditions like diabetic, hypertension, and obviously dyslipidemia, ischemic heart disease, from mental to whatever, which you have summarized very well in your presentations. And what's your intake regarding that definition? Do you think is well qualified? Do you think we should actually be using that? Because when you see an obesity patient, he's no longer just a normal person, but a patient with a lot of problems. And second issue is about the issue about the obesity paradox, which is like where there's a lot of research which was done, and some of the finding was that actually obese patients tend to do better than actually people that are skinny when they're in critical care. So they tend to have better outcome. And, and then I think you've also quite alluded a lot about obesity and osteoporosis. do obese patients get osteoporosis? That's a three simple question.
Okay. The first one was about the naming.
A, B, C, D, yeah. And we
I-
add E for excessive fat. Yeah.
So, I mean, it's definitely chronic and it is related to adiposity. So I think, that the name change is, it makes sense. I think obesity as a term, the name, it has a lot of stigma. And there's also this, I don't know if it translates across the world, but in South Africa, as soon as you put obesity on anything for patients' medical aid, it suddenly sort of gets rejected and doesn't get covered as, which is, to me, is quite sad because, as you see, it's multifactorial. This is not somebody that is just necessarily eating too much. It's a disease with multi factors that come into play, just like any other disease. So yeah, if I will call it whatever, if I think the medical aid will support my patients in getting the therapy that I know they need.
I think that's the definition actually, because it tells you the chronic problems with other issues here.
Yes.
In terms of paradox, do you think obesity patient does well in ICU compared to the skinny people? Yeah.
I think it's controversial, and I think it's how you look at it, because or what subset of patients you are looking at. For example, if you're looking at a patient with COVID-19 or for example, in the peak of COVID and ended up on a ventilator, and that patient who's obese did not do better than somebody of normal weight. But in an older person who ends up in ICU for geriatric kind of population ends up in ICU, the thinking is that they do have a bit more of a reserve. And if they are emaciated and sarcopenic and they're already very frail, that person is frail. I mean, I think I've spoken about this before. They are going to do worse than the.
I think you're absolutely spot on, because the reality is that I think also, obesity, I mean, the age matters. I mean, if you're between age of 20 to 60 years old, your risk, if you're obese, the risk of cardiovascular disease, the risk of neurological issues, cancers, everything are very high. But I think obesity is probably well tolerated after the age of 70. So I always advise my patients with COPD that come to see me from age of 70, I always encourage them to pick up weight. Because I think by age of 80, naturally, you start losing muscle bulk because you become less mobile, and somehow you start a lot of things start setting in, depression, whatever. So obesity is okay from age of 70 above. I think below that, I think people need to try to exercise, because I think especially women between age of 40 and 60, they should not be obese, because that's where a lot of complications set in. Males from age of 30, probably very important, because I think when you go above age of 35, you become too busy, and then less the sedentary lifestyle also increases, and then the risk of obesity increases, a lot of complications, cardiovascular, and the list goes endless. I think for me that's very important. I think when actually you get obesity, and then also obesity, osteoporosis.
So the obese patient that is mobile and is walking and weight bearing, they are less likely to have osteoporosis. The obese patient that is so obese they're not able to mobilize and they're always seated, they are going to have, they're really not moving around, but bearing their own weight, they can have osteoporosis. And then if it's a secondary cause, like if you have Cushing's, hypothyroidism, whatever, hypothyroidism, you're going to be obese, but then you can have.
And then final comment from my side regarding obesity with pulmonology patients. We see quite a lot of patients that present obesity through my practice, and most of them really having quite a lot of complications from obstructive sleep apnea to obesity, hyperventilation syndromes, and not forgetting about lung atelectasis, pulmonary embolism, class 3 pulmonary hypertension. The risk is quite very high, and I think one of Professor Wong from University of Witwatersrand at the Baragwana, head of pulmonology, did a beautiful presentation that's available on podcast at the Sanocare Bread of Hope podcast, which is YouTube channels, and the title was termed asthma and obesity, an egg or a chicken, which one come first? And that really probably highlight the impact of obesity in the lungs. Okay, so obese patient, obviously, when they do very well, very worse if they have a lot of lung issues because they post-obese patient, they get a lot of athletics, they go through respiratory failure. And I think there's a problem. Also, asthmatic, they become asthmatic. And in that case, we don't know. Is it the asthma start first or obesity? So it's quite a lot of nice podcasts there. And finally, to remind all the doctors out there that these presentations are available on our podcast channels, which you can actually get a links from the LinkedIn or from the Google. You just Google Sanocare Bread of Hope, and you will take you directly to the website. And the podcast is free. You can download them, listen to them, and it's educational. And thank you, guys. And Leanne, thank you for a great presentation. Dr. Engelbrecht, any question? Anybody online with a question? Let's check.
Hello.
Hello. How are you? We can hear you.
Hi, Emmanuel. Well, thank you, Leanne. Thank you this is Daniel here. Thank you for a great lecture. I just have one kind of question statement to Leanne, and yes. that is I read once in a book is that after age 40, is that you lose 1 kilogram of muscle mass per year, and it's replaced by fatty tissue. So your weight might stay the same, but you actually lose muscle. In order to maintain your muscle mass, you need to do a combination of aerobic and anaerobic, so weight training and aerobic exercise. But the thing that I find that most people have a problem with is that they say, well, I eat just as much as another person that weighs as much as me, but I'm picking up weight and they're losing weight. So how does it work? So I'm on 2,000 or 3,000 calories per day, 2,000 calories a day. And I always explain to them that muscle mass consumes much more energy. So you've got all our mitochondria. So a 100 kilogram muscle man can consume 2,000 calories a day, and he's actually going to maintain his weight. He's probably going to consume 3,000. But if you've got a 100 kilogram severely obese person that consumes 2,000 calories per day, they're probably still going to pick up weight because that fatty tissue doesn't consume any energy, it just stores energy. And I think that's the thing that people don't understand.
Yeah, it comes back to that balance, the intake and then the expenditure of energy. So like you said, the muscular person is going to burn more. That's why the two eating the same, one is going to gain weight and one isn't.
But I think it's an old story. Obese patients say they don't eat, and those who are skinny say they eat, but they don't pick up weight.
Yes,
so so we don't know who's telling the truth, but it obviously depends on the quality of food you eat. Yes.
It's what you eat. It's not always the quantity. You can be eating very small quantities of high carbohydrate foods, and you will gain weight. And the reason is because of your insulin spike that you get after consuming that carbohydrate-rich food. And then you end up gaining weight, from small amounts, small portion.
Any good question out there again, guys? Anybody online?
Yes.
31 people on.
Good day.
Yes.
Good morning, sir. How are you?
I'm all right. How are you? Welcome to our presentation.
Thank you very much. It's for the first time I enter your CBD board. We've got a lot of people who are not aware of this kind of training, which they seek the point as well as the knowledge. So I don't know how best can we assist them in terms of the link to join the message next time. But in the comments, I left my email. So can you please just kindly share the link so that I can inform them?
Okay, great. Thank you. I will do that. I think we'll first send you the link and also a presentation. Once you have an email, we can send you because we have presentation on every Wednesday and Thursday. And Tuesday, we have once a month microbiology. to assist the people to be able to make the right choice on antimicrobial. And Mondays, we're going to have legendary kind of presentation. Like I think sooner we'll have Prof. Feldman. We discuss about X-ray. So there are a lot of things that we're doing every week. We're definitely having something going. So most of the time it's via LinkedIn. Maybe if possible, you need to kind of probably connect with the LinkedIn Sanocare Bread of Hope, which we also will share. And that becomes much more easy. Then we can share everything with you. And it's really free of charge. We just wanted really to equalize knowledge that all of us should be able to manage patients properly. And if you look at our presentation, have no affiliation with any kind of pharmaceutical company. We wanted nice, normal knowledge for everybody so that we can speak in the same language. But thank you so much. And we'll share with you definitely, no problem.
Thank you very much, sir. Thank you.
Anybody out there? Okay, thank you guys. Appreciate it. Please do join our website and let's keep this thing going. Thank you, Lian. Video presentation.
Day.
Bye.